Number 3, increase the collateral flow. Number 4, prevent harm. So, Nancy is going to talk to you further in detail about how to do TPA, what kind of things to look for, but I'm going to talk about the pharmacology and the basis of using TPA. TPA was the first medication that was ever approved for treatment in acute ischemic stroke. It was approved in 1996, and it's been around for 20-some years. How does TPA work? TPA is tissue plasminogen activator. Let's go back into body's own hemostatic mechanism. How does the body form clots and how does the body lyse clots? Think about it simplistically. Let's say you're going from here to Hawaii. Nice, feels good, right? So you're taking this long flight to LA and then changing over to Honolulu, blah, blah, blah. You go to Honolulu, you want to have a great vacation. You develop a DVT. You don't even know you had a DVT, but you got up, you're fine, and you went about your business in Honolulu. You probably developed a DVT because of the long flight. But you're young, you're healthy, so your body lysed that clot in the leg, not even you knowing about it. How many of us could have had that? A lot of us. We don't even know. Because body has that internal mechanism to lyse the clot. Let's look at another scenario. Let's say you're cooking and you cut your finger with a knife. You bleed a little while, but you don't bleed to death, do you? You clot off. Why? Because that's body's mechanism to seal the bleeding. So, in other words, the body has a sealing mechanism and a bleeding mechanism, a clotting mechanism and a lysing mechanism. Are you following me? Okay. So, that balance between the clotting and the bleeding mechanism is the balance that the body maintains. So humans being as smart as we are, we decided to use that idea. So let's see what happens in actually a clot mechanism. So a clot is formed, any generic clot, not in the brain, anywhere. So let's even take that example of the little DVD that happens on your trip to Hawaii, right? So you form a clot, the fibrin at the endothelial cell, this is the vessel wall, you form a clot in your leg, it's a DVT. So, as soon as this clot hits the endothelial wall, the body recognizes, oh, something's not right here. So the body starts to release lytic substances. Plasminogen is a lytic substance. Plasminogen, once it contacts the fibrin, releases plasmin. So plasminogen, when it interacts with fibrin, forms plasmin, and plasmin lyses the clot. That's body's mechanism. But there is a helper here. See, the helper is hiding here? That helper is the tissue plasminogen activator. Let's say you're doing something, you need somebody to be a cheerleader, right? Somebody to make you feel better and help you do the stuff. So this tissue plasminogen activator is your cheerleader. So somebody said, okay, if I need this cheerleader to make the plasminogen, make plasmin and dissolve the clot, what if I give more of the tissue plasminogen activator? That will form more plasminogen, that will form more plasmin, and that will lyse the clot. Does it make sense? You have more cheerleaders so that the players can play better. That's the whole idea, right? So this is the mechanism of TPA. The body produces its own TPA, so now you're giving external TPA. So the external TPA is going to make more plasminogen, that's going to make more plasmin, that's going to dissolve the clot. Does this make scientific sense? You're basically using what body is doing and trying to enhance it for external mechanism. Make sense? That's pretty smart, isn't it? Yeah. Okay, so remember I said when a patient comes in with symptoms of stroke, you do not know if it is an ischemic stroke or a hemorrhagic stroke unless you do a CAT scan. So first thing we do is we do a CAT scan. If there is bleeding in the brain, That's hemorrhagic stroke. No, we don't do anything. It's a bleeding stroke. We cannot give tissue plasma inactivator. But if there's no bleeding in the brain and the CAT scan shows no evidence of bleeding, then that patient potentially is an ischemic stroke. Why isn't the CAT scan showing a stroke right away? The CAT scan does not have the ability to pick up stroke right away. It takes several hours, sometimes even days. If you look at the CAT scan on day 1, day 2, day 5 is when you actually see a nicely formed hypodensity, which is a stroke. So, once we know that it's not a bleed, it's an ischemic stroke, then we consider the patient to be a candidate for TPA. What is the science behind it? They did a clinical trial comparing TPA to placebo in 1996. They found that compared to placebo, less people died in the TPA group than in the placebo group. This is a score called modified Rankin scale. This is a disability scale. 0 to 1 means you're normal with a little bit of deficits, 2 to 3 minor deficit, 4 to 5 moderate deficits, and black, death is death. So people who got TPA, less people died, and there were more people in the minor deficit group than in the placebo group. So this was tested within a wide range of windows. They did it for people under 3 hours, and 6 hours, and so on and so forth. Under 3 hours is when they found the most benefit. Under 3 hours, if TPA is given, more people got benefit from TPA than people who did not get TPA. But for 6 hours, it did not work in the United States. Fortunately, I was one of the principal investigators who was involved in the study for 6 hours. But the Europeans said, hey, if 3 doesn't work and 3 works and 6 doesn't work, why not do 4.5? Kind of an idea, right? Europeans always think outside the box. So they did it, and in 4.5 hours, what they found was, yes, it was better than placebo, but not as robust as it was under 3 hours. Look at this. See the difference? It's still TPA is better, but not as good. So they said, hey, something better than nothing. If it is that one patient that you could save, who comes in at 3.5 hours, why not save that person, right? So TPA was now beginning to be used up to 4.5 hours. But the FDA still has not approved TPA for up to 4.5 hours in the United States. Although there is data to support it, FDA has not approved it. It's been a number of years. So if you are going to give TPA to a patient up to 4.5 hours, beyond 3 hours, you have to get a consent. Under 3 hours, you don't have to because it's approved by FDA. But after 3, up to 4.5, FDA has not approved it. They didn't say they will not approve it, but they haven't gone that way. If you guys want to do it, you can do it, but you need to get a consent, you need to tell the patients. You got it? So, when we first started doing TPA, we said, well, I have 3 hours, and I'll finish my office and do whatever I need to do, and then come and give patients TPA. Well, as time went on, we realized that is not a good thing. So, when they did, TPA came out in 1996, in 2000 they did a study, they looked at all the patients who got TPA. People who got TPA within 90 minutes had barely any deficits. But people who, you can see nothing here, but people who got TPA at 120 minutes and people who got TPA close to 180 minutes, they had a lot more damage. So the moral of the story is, the sooner you give TPA, the benefits are better. The later you give TPA, although you are giving TPA, it's not as good. You see what I'm saying? So if you give sooner, the clot doesn't form up, so you can break the clot better. But as time goes on, the clot becomes harder. I mean, I'm just making it very graphic. It becomes harder, and it's very hard to bust the clot. So, for many, many years, we had this information. We said, okay, we'll come running. Robert. will come running and take care of the patient. Then as time went on, we figured out that, it's impossible for us to run over from the office and take care of patients, so we started putting neuro-hospitalists in the hospital who could be there to take care of these patients and give TPA. Thank you. So, then came the era of endovascular thrombolysis. So people figured out, the number of people who get TPA through this mechanism is only 5% because of this one problem. When people go to, the last time they were found to be normal is the time that we consider as the time of onset of their symptoms. Let's say Mr. Jones went to bed at 10 o'clock, he got up at 6 o'clock, and he had right-sided weakness. The time of onset is considered to be 10 p.m. Will he qualify for TPA? Nope. Time of onset is not there. Second problem people started to encounter was that people are not seeking immediate medical attention, which is still the case. They don't know the signs and symptoms of stroke. Third problem is we have not mobilized our systems with bells and whistles and come to the emergency room. Even if they recognize the symptoms, even today, many of the patients we see, they walk in with symptoms. They don't call 911 for more than one reason. Number 4, we did not have enough hospitals, enough specialists to do this. So many patients, although they've had stroke symptoms, if they didn't present within 3 hours, and if the hospital was not equipped, they didn't have doctors, only about 5% in excellent hospitals even got TPA. In most of the hospitals, it was 2%. So then people said, hey, wait a minute, what if I directly go into the brain, do a rotor and suck up that clot and get the clot out? Pretty dicey idea, right? I said, okay, let's try that. So they started using all these equipments, intra-arterial, mechanical, what they were trying to do. So, this is how they go. They go in. Remember, these blood vessels are not this big. They are about 2 to 3 millimeters. And through that, you have to send a catheter. And inside there's a clot. It has to sit there, soak a little bit. So that is endovascular treatment. So people were doing all these endovascular trials and so many IMS 1, IMS 2, IMS 3, all the MR rescue, MR this, MR that. All of these trials were meeting with failures. They would compare half the people with just IVTPA and other people doing this endovascular treatment. People who got IVTPA did better than people who got endovascular treatment. So they said, something is wrong, we're not doing something right. So they were like, I remember the meetings, we used to go to the meetings and say, what's wrong, what are we not doing right? People would have 18 different opinions and you would sit there and talk about it for hours. The Europeans were working very quietly. Remember I said, they always think outside the box. So in 2015, the Europeans said, what is the key to the success? The key to the success is to find out how much penumbra we have. Do we have collaterals? Can we do it in a timely fashion? If we have that information, we can go get the clot. If you don't have that information, you can't get the clot. So if you're going to buy a house, you need to know where it is located, what your mortgage is, and all the stuff. If not, you can't buy a house. Same way, we need that information. You just can't go blindly and go rotor inside the brain. So they said, by identifying a patients who had large vessel occlusion and finding those people who have large salvageable tissue, that endovascular treatment was successful. So we figured that out. We kind of figured it out. Well, this is the key. How do we get there? We know what it is, but we don't know how to get there. So, then came the era of CT angiography. So we were doing MRI scans, we were doing plain CAT scan. Then came the technology, CT angiography. People said, as long as you're putting patients into a CT scanner when they come in with a stroke to see if it's a bleed or non-bleed, why don't you give them a dye and see if the dye would pick up anything? So this is how the CAT scanner is. You put the patient, and now you're able to see the vessels. So what is the purpose of CT scan? To exclude hemorrhage, to see how big a stroke is. And if it's already on the CT scan, it is showing that there is a big stroke, then that's too late. CTA, CT angiogram, will look for occlusion. Where is the clot? Remember the guy that went up from here and sat in some place, took a road trip? Remember all that story we talked before? Yeah. We need to find where the guy is and find where the core is. Remember we talked about the core and the penumbra? Fine. So CT perfusion looks at the core and looks at the penumbra. So this is an example. I don't know how good you can see. You can see the blockage here. This is where the occlusion is. Now you can see the occlusion. See that? Here you have a good flow, but here there is no flow. Is there collateral flow here? No, no collateral. Good collateral. Very poor collateral. We talked about the anatomy. So, CT perfusion. Why do we need CT perfusion? Because we want to see how much penumbra we have. And what is our mantra? Save the... There we go. So, story here. Core, penumbra, occlusion. So CTA is going to show the occlusion. CTP is going to show the penumbra. You got it? So now we're going to do some fun stuff. Core, penumbra. At least you need to have 20% penumbra to go and get the brain. If you don't even have 20% penumbra, what's the point? What are we trying to say, right? Okay, now, this is the blood volume. This is how we look at the penumbra. These are called perfusion maps. Okay? No tissue addressed. So the core and the penumbra are just about the same. You can save the brain. It's all. This is the core. This is the core. This is the penumbra. Can you save this brain? 54-year-old male came in with left hemiparesis. He already has a stroke, which means he came late. We did the CTA to see where the occlusion is. Right MCA is occluded. You can't see anything. Now, let's look at him. You will go after him. Core, penumbra. Will you go? Core is the core. Remember you saw in the CT scan. This is the core. But look how much penumbra he has. He's 54. Another case. Will you take this case? Why? Small core, big penumbra. Small core, big penumbra. Will you take this case? You guys are becoming good radiologists already. I'm impressed. Why? Why wouldn't you take this case? Core's big, no penumbra. Will you take this case? Will you take this case? Maybe. Will you take this case? Will you take this case? Wow, I'm impressed. So, these were the smart Europeans. They did a study called Mr. Clean. Clean, Mr. Clean. So Mr. Clean was the first study That came on December 31st, 2014. I remember the exact place that I was sitting when I got the study. They said, if you are able to get to the occluded vessel with a small core and penumbra within 6 hours, patients who got the intervention did much better than people who just got IVTPA. Well, it's not only the Europeans, the US, the Australians, the Canadians are also equally smarter. So we said, you're just only 2 months behind you. So we came with a vengeance. On February 2015, I was lucky I was in this conference in Tennessee. They presented ESCAPE, EXTEND, IEA, SWIFT, PRIME, 3 clinical trials. One from Australia, one from Canada and the US, one from US alone. All 3 trials showed a statistically significant difference between the endovascular therapy group and the best medical management as measured by the disability scale. Wow. So then they had 2 more trials called RevSCAT and another one. All trials showed that statistically significant improvement in patients in select patients. The select meant the ones that had the occlusion, one that had the small core, one that had the large penumbra. So in select patients, within 6 hours, if you get them on time, you are going to see a benefit in these patients. This is doable. I mean, there are how many patients? How many centers are they coming? Or do we have the capability to do this? So everybody said, wow, the Europeans did it, the Americans did it. Can we do this in Old Town Melbourne? I said, yes, we can do it, right? So we started doing it. We started doing it in 2013. We did a number of cases. We did 2 cases in 2012. We did about 24 cases in 2013. 6 cases in 2013, 2014. The number went up 2015. We did 56 cases. This year, we have done 86 cases so far. Numbers are going up. So we were only doing up to 6 hours. Then came another study that said, hey, we can do up to 8 hours. That's even better. Then came another study that said, hey, we can do up to 24 hours. Okay? So that result was presented this year in our stroke meeting in January. The DAWN trial compared people, that DAWN trial is a long name, they compared the clinical outcomes in 90 days with the stent retriever compared to medical management in appropriately selected patients treated after 6 hours, after 24 hours. So 6 to 24, then you will include the under 6, because we already know we have data for under 6. We're going to treat them with the European studies and the American studies and all that. So patient has symptoms, comes to the hospital, they do a CT, CTA, CTP, or MRI, and then they get treatment. Control is just IVTPA, then the other group gets thrown back to me. What is this? Big penumbra. So they all have to have that. And this is the clot that they took out. Look at this. You saw this thing before, right? The bar. This is the one that had the treatment. This is the control. Look at the MRS. If you look at it, 73% relative risk reduction on dependency of activities of daily living for people who are treated with endovascular treatment than people who just got IVTPA. So they said, okay, compared to standard medical therapy, where 48% of the patients were dependent, here only 13%, 48% versus 13%. So for every 100 patients treated with endovascular treatment, 49 patients will have less disability as a result of treatment, including 36 who will be functionally independent. That's an impressive number. So for every 2 patients you treat, 1 patient will get better. That's a great chance. Then came another trial called the DIFFUSE trial. Actually, DIFFUSE came a little bit later than DAWN. DAWN came last November, and we were thinking, wow, 24 hours, are we really going to be able to do this? Is this data real? Should we jump into the bandwagon? Should we do this? We were all debating. Then diffuse was presented. Diffuse took patients from 6 to 16. 6 to 16 also was beneficial. So once we saw 6 to 16 was beneficial, then we began to have more faith and more belief in the 24-hour trial, because now almost overlappingly we are getting benefits. So we got more confident. So 6 to 16 patients, selection by perfusion imaging. That is with your CTA and CTP, looking at the core and penumbra. You can't take anybody and do it left and right. You've got to select the patients. They need to have good collaterals. They need to have a clot demonstrated. They need to have good core. They need to have small core and a large penumbra. Again, it was very beneficial. It was conducted in 38 US centers, and the trial was so good, FDA told them to stop the trial halfway through. They said it is unethical to do it on patients without the trial, because it was so good on the treatment arm. You can't include the placebo arm in there because that's not good for them. You're killing them because you already proven that it was good, so the trial was stopped. So the 90-day mortality was 14% in the treated group versus 26% in the medical group. And there was no significant difference in the hemorrhage. You would think that you go to Roto-Rooter, you're going to bleed, no? And even the serious adverse events was not any different. So look at this. So, when we came out of the meeting, Nancy and I, we came from the meeting on a Saturday night. Monday morning at 7 o'clock, we had a meeting in my office. How are we going to change this in Brevard County? People are looking at us like, what? Somebody said something in the international meetings and you want to change it in Brevard County, and Nancy and I said, yes, we are changing. We had the ED doctors, the EMS people, all our administrators and everybody, and said, we are doing it. And we started doing it. And we started doing it. And we're still doing it, and we'll continue to do it. So, the clock, 0 minutes onset of symptoms, within 3 to 4.5, you have to give them IV TPA, and within 24 hours, if they have an occlusion, a small core, and a large penumbra, you can take them for endovascular. Now you know the science behind why we do CTA, CTP in the community hospitals, and so on and so forth. So in Brevard County, within 2 weeks, they changed their entire protocol. So that's what they bring in the case. So now that I've dealt with the ED, Nancy later on is going to come back and tell you how we do the protocol in reality. How do we do TPA? How do we do CTA, CTP? How do we transfer patients from community hospitals? Just because a patient comes to Cape Canaveral or Viera doesn't mean that they cannot get endovascular. So Nancy and I said, wait a minute, at home if they come they can get it, but what if they come to Viera? How are we going to treat them? So we said, let's devise a system. So we developed a clot alert system. And through that system, patients will be transferred, and we have many, many patients. You'll see a woman on the billboard wearing a blue outfit. That's one of our actual true survivors. She came to Cape Canaveral with a stroke symptom, was transferred to home. She got IV TPA. She had clot removal at home, and I see her in the office. She goes back. She's a real estate broker. She's really doing well. So now let's talk about the hospital management. I'm talking purely science. Nancy's going to talk about what nurses have to do. What are the 5 main reasons for admission? Stabilization and prevention of progression, identify the etiology of stroke, treat complications, initiate rehabilitation, and last but not the least, educate them. You don't want them coming back again and again with more strokes. Remember, 41% of stroke patients die within 5 years because of untreated risk factors. So the first phase, up to 24 hours, is called hyperacute phase. Then the second phase is called acute phase. We do invasive monitoring. We do an eye stroke scale on all stroke patients. We monitor them for bleeding complications. We monitor them for pneumonia. We monitor them for infection. General supportive care. Stroke kills less than 5% of the patients. Complications from stroke kill more patients. So if you're saving a stroke patient, the credit goes to you, not to us. as doctors. We've done our part. We've done our part of treating them in the front end. We are doing our part of finding the cause of stroke, to prevent them from having pneumonia, to prevent them from having a seizure, to prevent them from having a DVT lays on your hands, the nursing hands. So that's why that preventing the complication is extremely important. Early mobilization. If they are having swallowing problems, because 35% of stroke patients have aspiration pneumonia. Because remember we talked about how the mouth is highly represented in the brain. When you have a stroke, the swallowing mechanism is the first thing to go. It'll come back later, but if you don't know that, and if you don't treat them, and you go ahead and give them food or something like that, they're going to aspirate, silent aspiration. And as long as I'm here, I'm going to tell you something, please don't forget it. We do not need stroke patients to get an aspirin in the emergency room. Maybe you do it for MI patients, but for stroke patients, please do not shove an aspirin down their throat. We do not need that. Within 48 hours, they can get their aspirin. Aspirin in the emergency room is not going to make any difference in their outcome. On the other hand, by shoving that aspirin down their throat, you're going to increase the risk of aspiration, not knowing if they have an intact swallowing mechanism. So please do not give aspirin in the ED to stroke patients. And sometimes you do not know, these patients could get hemorrhage after the stroke. They could have hemorrhagic complications if they have AFib-related stroke. Please don't give aspirin to make it worse. Stay away from aspirin in stroke patients. That's the job of the floor nurses, not the ED nurses. Early mobilization, bowel and bladder care to prevent UTI, other complications. Don't let the patient die of complications. Aspiration, hyperventilation, pneumonia, MI, arrhythmias, DVT, PE, UTI, decubitus ulcers, stress ulcers, malnutrition, contractures, neurologic complications, cerebral edema, hydrocephalus, increased ICP, hemorrhagic transformation, and seizures. So, now, we are going to do the evaluation of the causes of stroke. So the etiology of stroke. Remember one thing, different strokes for different folks. Stroke is not a unified disease. It is heterogeneous. Different people have different types of ischemic stroke. The etiology is different. I once had a gastroenterologist who asked me, what is up with your neurologist? You guys always do MRI, CT, this, that, and the other. I said, well, we are dealing with the top of the brain. You have a lot of those things. You only do your scopes. I'm not going to tell you how. Leave it alone. So we do different strokes for different folks. Ischemic strokes, we are going to find a different etiology. About 20% of them are caused by carotid artery blockage. About 25% of them are caused by small vessels in the brain getting clogged up due to many, many years of untreated hypertension, diabetes, hypercholesterolemia. 20% of the strokes are caused by cardioembolism, and 30% of the strokes are cryptogenic. We still don't know the cause. So this is, again, remember I said 85% of ischemic stroke, hemorrhagic is about 15%. There are two types, and ischemic strokes, these are the etiology. What are some of the diagnostic procedures we do? We do a CAT scan, which we do in the emergency room to see if it's a bleed or an ischemic stroke. We do an MRI, MRA. MRI looks at the strokes within minutes. It localizes the stroke. It looks at the size of the stroke. It can pick up symptoms very quickly. MRA looks at the blood vessels in the brain, just like the CTA. We do not do MRA in the emergency room because it's very hard. Patients are claustrophobic and they could have pacemakers, and it's very hard for a 45-minute drive. Whereas CTA, which gives the same information, it's also able to give us the penumbra on the core, and it can be done in less than 20 minutes. That's why we do CTA. Carotid ultrasound looks at the plaque formation. We do echocardiogram to see if there are clots in the heart. Sometimes we do transcranial Doppler. We talk about CT angiography. In very rare cases, we might have to actually do an angiogram where we inject a dye in the groin, just like the heart can, and it goes into the brain to look at all the vessels. We also do some additional lab tests to see what their lipid profile is. Remember, stroke patients also are at risk for MI, so cholesterol, high cholesterol is one of the risk factors. So we do a lipid profile. MRI scan can detect a very tiny stroke in the brain and a large stroke, and when it is positive within minutes of onset of stroke symptoms. MRA looks at the blood vessels in the brain. CTA also looks at the carotid vessels and arteries inside the brain. CTA and MRI can also detect small aneurysms in the brain. So let's talk about large artery disease. Large artery disease is caused by formation of plaques in the carotid arteries. The carotid arteries start to develop plaque with many, many years of uncontrolled diabetes, high blood pressure, cholesterol, smoking. So these plaques form progressively. They say as early as age 2, you start to seeing plaques in the carotid arteries. And as they start to build up, one fine day, for no reason, nobody knows when, why, how, the plaques rupture. And the plaque ruptures, it becomes very thrombogenic, which means it becomes very sticky. When it becomes very sticky, what's going through the blood vessels? Blood. So the plaque ruptures, the blood vessels which carry the blood have platelets. The platelets stick on to the ruptured plaque area. So the plaques ruptured is like open. The platelets stick onto that area. So what happens when platelets stick together? Form a thrombus. And the thrombus, if it remains in the vessel, it's thrombotic stroke. If the thrombus breaks and goes downstream, it's called? Wow, you guys are a sharp group, man, I'm impressed. So that embolic stroke can happen. So now this is the carotid artery. This is the patient I took care of when I was in residency. The studies, fortunately, I've been very fortunate. I have lived through these years of tremendous development in the area of stroke. The NASID was a clinical trial that looked at the benefit of surgery versus just aspirin for patients who have carotid artery disease and who have stroke symptoms. It showed that under 50%, let's say your left internal carotid artery has less than 50% stenosis, and you have a stroke in the left side of the brain, do not do surgery because it's not beneficial. But if it is above 50%, up to 99%, you have to do surgery. The sooner the surgery, better it is. But in some cases, we may not be able to do surgery right away because they have probably had massive strokes. Well, when carotid, and this is called carotid endarterectomy, this is out in 1992, the results were out, very, very robust study. People started doing carotid endarterectomy. Around the same time, the cardiologists started to put stents in the heart. So then we said, hey, why not put stents in the carotid arteries? Because some patients cannot undergo carotid endarterectomy because they cannot go under anesthesia, or they may have a bad heart. So this is an example of a patient who one of my colleagues from Cleveland Clinic gave me. This patient has severe heart disease, and look what a tight stenosis. He has double whammy on both sides, left and right, and he had to have bypass surgery. So he's got a bad heart, so he couldn't go under, but he had bilateral carotid stenosis. So they put a stent and opened up the vessel. And people said, wow, everybody's getting stents. Maybe stent is the way to go. Maybe nobody should get carotid surgery. Then they said, wait a minute. And too many stents were happening. Throughout the world, everybody was doing stents. And then that became a cottage industry. They started getting into complications of stent. Then the government said, wait a minute. Let's hold on. Let's do a clinical trial. Have the patients go on stent. Have the patient do surgery. Let's see who wins. So that trial was called the CREST trial. Who do you think won? Stent or the surgery? Be honest, be honest. Surgery? Okay, you all think surgery because I told you so, right? Okay, hold your thoughts there. No change, no difference. No difference between the primary endpoints of stroke, MI, and death in the carotid stenting group versus the endarterectomy group, 7.2 versus 6.8, p-value was not that high. Same thing, procedural complications, everything was pretty similar. So, what did the government say? CMS said, you can do either or, but For a patient to have a stent, the patient should qualify for a stent. In other words, the surgeon should say, I will not touch this patient with an 8-foot pole because it's too risky, because of heart or whatever. Or for sometimes we can see patients who had scar tissue. I've had many patients I've had in my practice who had radiation for head and neck cancers when they were young, and so that cured the cancer, but then the scar tissue started forming in the carotid arteries, and these people start getting carotid artery blockages as young as 40, 50 years of age. And in these patients, you don't want to go and do an operation, because you do an operation on the vessel, what are you going to create more? More scar tissue, and you're not doing them a favor. So in these patients, stent would be a lot easier. So, and for sometimes you have patients who have a very strange anatomy. They have a very loopy blood vessel, and then the loopy blood vessel could be way up here instead of down here. If it's way up here and the vessel is loopy, how is the surgeon going to go here? And if the vessel is looping around, how can he do surgery? In those cases, stent is preferred. So, stent is still being done, but on select cases, so we have a team, the surgeon, the neurologist, and the endovascular guy. They will say, okay, this patient cannot have this patient cannot have this. I have a patient I saw yesterday. He has high-grade left carotid stenosis. He has AFib. He has a low ejection fraction. He's on dialysis, and he ended up having a stroke. What do you do to this guy? Do you think any surgeon is going to touch this guy with an 8-foot pole? No. So this, he also has AFib. He also had a GI bleed. He's only 84 years old. But this guy has had a stroke. So this is the kind of a guy, the high-risk guy, that we usually take them for stents. Now you understand? But straightforward 72-year-old who presents, who's got a little TIA, who's got high-grade carotid stenosis, yeah, go into a carotid endarterectomy. So, we talk about carotid disease. Atherosclerosis can happen anywhere. It can happen from here to the arteries inside the brain. Remember we talked about the circle of Willis? It can happen there too. After the plaques can build anywhere it wants. So you can have plaque formation inside the brain. That's called intracranial atherosclerosis. Simple, right? Inside the brain, cranial atherosclerosis. But this problem is a little bit more common in African Americans and Asians. For some reason, they are more prone to having that. They say about 8% of the patients do have intracranial disease. The bad thing about intracranial disease, these patients don't generally have TIAs when they present big with a stroke. And these people also have a high risk of myocardial infarction because the size of the vessels inside the brain is the same size of your coronary vessels. Well, for those patients in the past, when I was in medical school, we used to use warfarin, but now we don't use warfarin anymore. Aspirin and Plavix are equally good. This is a guy, you see the old slide, how old it is? This is a guy I took care of in 1994. There was a hurricane. Actually, the guy was from here. I was at the clinic. He was sent to me as a second opinion case. After the hurricane, he was, trimming the trees or whatever. And every time he looked up, he would become paralyzed and fall to the floor. They thought it was the heat. No, it was not the heat. Look. He has a very, very tight basilar artery stenosis. We put him on Coumadin, we put him on aspirin, we put him on Plavix. No, nothing helped him. He kept falling, he kept passing out. So what did we do? We put a stent. Tight vessel, we opened up with a stent. Then people said, wow, stent works for arteries inside the brain. So everybody started doing stents. Then what happened? More problems with stent. More bleeding with stent. Then what did the government do? Guys, hold on. They did the same thing. Half the people went on the stent, half the people went on aspirin Plavix. Who do you think won? How many people for stents? How many people for medical management? I think this side's going to win. Yes, the stent people had a worse outcome. The death was 14.7% in the stent group, whereas it was 5.8% in the medical management group. So they concluded that if people have strokes caused by artery blockages in the brain, you're better off treating them with medications, aspirin, Plavix, and controlling the risk factors with statins instead of putting a stent in the brain. But there are some patients, in spite of taking Plavix and aspirin, in spite of taking a statin, in spite of controlling the diabetes, they still have strokes and so. And those patients, they do allow stenting in the brain because that's a very high-risk procedure, as you're seeing here. So you just don't want to give stents out randomly to anybody. So you really have to select that high-risk procedure. So you have to have 2 strokes, recover from the stroke, you have to be good, take all your medicine like a doctor prescribed, and still have strokes. So as a last resort, you can have the stent done when everything else fails. The stent is not cheap. It's only about $35,000. So they do approve the stent. It's called the wingspan stent. And so, but you have to have some criteria. So now we move from here to here. Now let's talk about cardioembolism. I always say the heart is the source of all the problems. You agree? Okay, see? So what happens? In cardioembolism, the heart has several problems that lead to a stroke. Atrial fibrillation is the most common cardiac source. You can have an acute MI, you can have a ventricular aneurysm, you can have rheumatic heart disease, not so common in the Western world, prosthetic heart valves, other common sources. I had a guy yesterday, he was 60 years old, he was a drug abuser, and intravenous drug abuser, and he ended up having strokes, and now he's in a nursing home. I asked him point blank, were you doing intravenous drugs? I guess so. What do you mean you guess so? That's what the doctors say. I said, what did you do? He powdered OxyContin, mixed it with sterile water, and shot himself. And he had vegetations in his heart, which went to the brain, and fortunately, he came to the hospital in time, and Dr. Shaheen took the clot out. Now the guy can walk a little bit, of course, he's still in a nursing home. You think you'd be very thankful? So this is an example of AFib-related clot in the heart. About 2.5 million Americans have atrial fibrillation. Now it's not actually 6, it's an old slide. 1 out of every 5 strokes is caused by AFib. Strokes from atrial fibrillation usually, like the top of the brain, they affect the cortex of the brain. They're usually massive strokes. This is a nasty thing. Remember that little guy, the plant that goes and parks itself in the small vessel? If that plant comes from the carotid artery, it just blocks the vessel, it makes the brain die, end of discussion. But the clot from the heart is mean. It goes up, it blocks the vessel, the brain dies, then the clot moves away. Might as well stay there, right? Why are you moving away? The clot moves away and then fresh blood comes to the area of dead tissue and makes that area hemorrhagic. It's like you already have 4 days of rain in your yard. On top of that, you have another thunderstorm, so you have puddles of water in your yard. That's what happens. What is the problem with this? Because most of the cardioembolic strokes are caused by atrial fibrillation. And what is the treatment for atrial fibrillation? Anticoagulation. How can I anticoagulate somebody who has a hemorrhagic conversion of their ischemic stroke? So it's a catch-22 situation. You have a stroke, the stroke becomes hemorrhagic, the stroke is because of AFib. Now I need to anticoagulate you. It's going to take me 2 months for all the blood to get away from the brain, heal, and then only I can put you on anticoagulation. So in those 2 months, you have more risk of stroke. It's a catch-22 situation. You can't help it. That is why we are going very, very hard on patients with AFib and say, don't let that happen. You go ahead and anticoagulate before the stroke happens. Be very preventative. AFib is the leading cause of hospitalization in the United States. the prevalence of atrial fibrillation increases with age. I was giving a community lecture last week, and then this one guy comes up to me and he said, well, you know, if I live up to 94, I won't have AFib, right? So all you need to do is live up to 90 or 94, and my bell curve gets better, so I don't have to go on blood thinners. I'm thinking to myself, yeah, you're right, but you need to go up to 94 if AFib doesn't get you by the time. I'm like, come on. He was looking at the bell curve. But I'm saying first you have to pass 60, 70, and 80 before you go to 90. So what's the problem in this age group? What's the problem? They have a lot of comorbidities, dementia, walking problems, cancer, lung problems. More than anything, these people live alone. Some of them have lost their spouses. They're all in our sunny belt of Florida. They're all snowbirds, and their families live up there. So these people have a lot of stroke risk. They don't know what to take care, who to take care. So that's why we are so much promoting for prevention. As you can see, this is a scoring system called the CHAD score. As you increase the risk factors, recent CHF, hypertension, age above 75, diabetes, risk of a prior stroke, your stroke risk goes up substantially. And you see, I saw a guy yesterday, he had a stroke in Oregon when he went for a family wedding, and he has his Japanese heart failure. He's about 76 years old, he's a diabetic, he's already had a stroke, and he has hypertension, and he's a kidney transplant patient. And he had a stroke, and his wife is a nurse, and they had a lot of reservation about going on anticoagulation. I said, look, your CHAD score is 18.2%. Plus you already have had a stroke. Fortunately, you recovered well, and you have AFib. You need to go on anticoagulation, and then they agreed, and I put them on medication. So many years ago, we did 8 clinical trials, and one of them called SPAF2 clearly indicated that warfarin is better than aspirin. Anticoagulation is better than antiplatelet therapy. So for a number of years, we were using warfarin. It decreases the frequency of all strokes by 68% with an absolute annual reduction of 31%. The risk reduction was greater for women than for men. But the INR needs to be kept between 2 and 3. If you do keep the INR between 2 and 3, the bleeding risk is only 1.3% compared to 1% for aspirin and placebo. As long as you keep the warfarin there, you're going to be fine. But unfortunately, warfarin is a very difficult drug to manage, like we all know. The medications, interactions, the foods that you cannot eat, the monitoring, a lot of these patients don't come on time. So only about 35 to 40% of the patients at best, and that too, only in the Northeast, we are bad. Southeast, we are not even 30% in the United States of anticoagulation. However, over the years, we have actually done a good job. If you look at from 1992 to 2002, 1992 when the SPAC trial came, saying that warfarin is better, the use of warfarin has gone up substantially from 20% to 60%. The stroke risk has come down nicely, and the hemorrhage risk has remained stable. So we are doing a good job. However, like we said before, warfarin is a difficult drug. So people started coming up with different anticoagulants, dabigatran, rivaroxaban, and apixaban. How do these things work? If you can't sleep, go through this cascade. But we won't go into that. I'll give you a simple example, just you gotta remember. You want to go from I-95 to the beach. And I'm going to say, I'm going to stop you from going to the beach no matter what. I can stop you at many places. I can stop you at I-95. I can stop you at US 1. I can stop you at Pineda Causeway. I can stop you at A1A. Regardless, you're not going to the beach, because I'm determined I'm not going to let you go to the beach. That's the way these things work. If you look at warfarin, warfarin works at I-95 level. So you can't even get to the roads to get to the beach. You cannot even get to the coagulation cascade, because warfarin acts on these factors, the intrinsic factors, all the factors that cause coagulation. If you looked at dabigatran, it stops at thrombin level, okay? It stops at thrombin level. That, for example, it stops you at US1 level. You can't get to the clot. So if you look at, I'll come to it in a minute. If you look at apixaban and rivaroxaban, it stops at factor 10 level. So it stops you at A1A level. So I always have this thing, how do you differentiate between factor 10 and thrombin inhibitor? I'll give you a little tip. Apixaban, rivaroxaban, look at the X, Roman letter 10, right? X is a Roman letter 10. So apixaban and rivaroxaban, which is your Xarelto and Eliquis, stop the coagulation cascade at factor 10 level. Pradaxa, on the other hand, works at the thrombin level. TH, TR, I remember T and R, dabigatran. That's how I remember, because too many of these drugs I get a little confused. So, the main clinical trial that they did was a RELY study. They looked at dabigatran 150 milligrams. It was increased efficacy, non-inferior. They compared these drugs to Coumadin. Coumadin we know was great, but we wanted a drug that was better than Coumadin. So when they looked at a dose of 150, it had increased efficacy, but decreased bleeding was just about the same like Coumadin. But at a lower dose, they had non-inferior efficacy and lower bleeding. The FDA only approved 150 milligrams in the United States and then 75 milligrams. In Europe, they approved 110, but now I'm seeing a lot more patients on 110 milligrams. Yesterday, I saw a patient was on 110. I was kind of curious why they did that. Whereas Xarelto and apixaban also work on the factor 10 mechanism, and apixaban is approved as well, and rivaroxaban is also approved. All these medications have really revolutionized the way we treat atrial fibrillation. Once you find atrial fibrillation, you don't have to put them on Coumadin, you put them on these drugs, and you're not going to have much strokes. But we do know that these drugs also go through the kidneys. They're all excreted through the kidneys, so you need to adjust the dose according to the kidney function. Like the guy I told you earlier who had renal failure, was on dialysis and all that, I had to adjust the dose because of kidney function. So we talked about carotid stroke, intracranial disease, cardioembolic stroke. Now we talk about lacunar stroke. Lacunar strokes are tiny strokes that are caused by small arteries in the brain getting clogged up. These arteries, you know how small they are? You take your hair and split it, not like this, into 1,000 pieces. And you take one of them. That's how thin these vessels are. And these vessels are bombarded with many, many years of hypertension, diabetes, high cholesterol. What's going to happen? One day it's going to say enough is enough. It's going to close off. And then the little platelets that go through the vessel get sticky, sits there, causes a stroke. So that's called lacunar stroke. It's caused by small vessel atherosclerosis, multiple risk factors. You can see it on CT and MRI. The stroke recurrence rate is 12% in the first year. How do you control it? Risk factor control, especially diabetes, hypertension, controlling the lipids. I saw a guy yesterday, education. If you don't educate yourself, how can you go educate a lay person? You guys are all educated professionals, so we are giving these classes to empower you with that education so you can go and help the patients. So, in conclusion, stroke is a major problem, especially as we age. Many risk factors contribute to the prevalence of stroke. We need global risk reduction. 85% of the strokes are ischemic. Prevention and education are the keys to decreasing the incidence of stroke. Thank you very much. I'm available for questions. Any questions?